Welcome to GN and 10, a bite-sized podcast brought to you by the International Society of Glomerular Disease. Our hosts are nephrologists and glomerular disease experts, Dr. Kenar Jhaveri of Northwell Health and Hofstra University on Long Island, New York, and Dr. Koyal Jain from the University of North Carolina, Chapel Hill.
Welcome to GN and 10 with Koyal Jain and myself, Kenar Jhaveri. And this is our board review bonus. We've been doing these sessions with different glomerular diseases. And today's special topic is lupus nephritis, which a lot of people need to know about, I'm sure, both rheumatologists and nephrologists. We also have a very special guest. It's the first time we're doing this. So we actually have a fellow in training here at Northwell, Dr. Mahmoud Abdelaziz. Since this is a board review special, we felt a fellow's perspective or fellows asking us questions might be better.
I'm happy to be here.
Welcome, Mahmoud. You are our very first fellow on the series of podcasts.
So lupus nephritis. Let's start with diagnosis.
What does Mahmoud want to know? What do you want to know as a fellow?
I guess the first thing I'd like to know is there's some clues of how we would suspect that there's kidney involvement in somebody with SLE.
I would say this is how I teach the fellows. So it's going to get really basics. I always think about three things, right? So yes, you have the extrarenal manifestation, but really boils down to three things. One is what's your kidney function doing? What's your GFR doing? The other one is what's your urine sediment looking like? And the third thing is what's your urine protein? So if you boil down to these three things, that's how I'm really trying to figure out whether somebody's active or not. So when somebody referred to me, my question is, hey, what's the UPC? How much proteinuria do they have? What does the urine sediment look like? Do they have acanthocytes? Do they have RBC Cas? Often you can also see just WBC Cas or WBCs in the urine with a lot of inflammation and may not see a lot of RBC Cas. And then is the creatinine much higher, the GFR is much lower. And that's really helping me determine, do I need to now biopsy this patient and determine if they have lupus nephritis?
Of what degree of proteinuria do you usually consider biopsy?
So I would say that if somebody has above a gram, almost always they get a kidney biopsy unless they've had like chronically some sort of like sclerosis and other things that we're thinking about, but typically above a gram for sure. And then above 500 milligrams, usually they'll have some other symptoms, right? Like there are 600, 700 milligrams, but they have a little bit of an active urine. I would still consider a biopsy at that time.
I think that's fair. I think the recent KDIGO guidelines also say exactly 500 milligrams of the cutoff.
Yes. I guess the next thing that's confusing is how we classify lupus and why that really matters.
Mahmoud and all the fellows, I think the role of the kidney biopsy here is going to be critical, right? Because the kidney biopsy, as Koyal said, that leads us to diagnose the histological classifications of lupus. And there have been a lot of ways to define lupus in the kidney, but the classic one is the 6 classifications we have. So that's the class 1 with minimal mesangial lupus nephritis. And it's very rare we see this because most of these patients don't get biopsied. They're normal urinalysis, minimal proteinuria, and normal serum creatinine. And it's just very minimal mesangial immune deposits. Maybe you will see basically an immunofluorescence and EM. You might have normal light microscopy findings perhaps. The second is class 2, which is mesangial proliferative lupus nephritis also. And here you might have some microscopic hematuria, some proteinuria, hypertension, but really maybe even normal creatinine here. We rarely again biopsy these patients, and you will have some mesangial hypercellularity in the light microscopy, and then you'll have some endothelial deposits eventually you see in the EM. Sometimes you can have a nephrotic syndrome with this, and then you'll have to think about lupus podocytopathy associated with class 2. And it's, again, very good prognosis when you have class 2. Class 3 to 5 is where we get the most worry. So focal lupus nephritis, or the class 3 variant, is where you have hematuria, proteinuria, and usually hypertension, decreased GFR, plus or minus nephrotic syndrome. And in here, this is where it's less than 50% of glomeruli that are affected by light microscopy. If there are more than 50% involved, then you actually define this as class 4. And there is active endocapillary or extracapillary glomerulonephritis, and you'll have some segmental component involved. And usually in the electron microscopy, you have this subendothelial deposits, immune deposits, and that's your classic class 3. Remember, all lupus nephritis patients have a full house pattern, so everything lights up in immunofluorescence, IgM, C1q, light, kappa, lambda, IgA, so it's the full house pattern. Diffuse lupus nephritis, or class 4, this is your diffuse proliferative class. This is the worst of the worst, where you have pretty much more than 50% glomeruli involved in light microscopy. And it's, again, the endocapillary, extracapillary glomerulonephritis. And this is your classic one that most of the time on the boards and in clinical practice, again, the EM is going to show a finding of subendothelial, maybe even mesangial deposits. You have the full house pattern. And in some cases that we have seen, you will have a crescentic variant. So remember, anything can become crescentic, any GN. And the one that does become here is usually class 4. And then finally, you have class 5, which is a membranous variant of lupus, where you have the membranous pattern of injury. So it's not proliferative pattern. It's not an MPGN pattern. It's a membranous pattern on light microscopy. And the IF will be full house and the EM will have subepithelial deposits. And this is your classic membranous pattern. And then class 6 is really just end-stage kidney. So you'll have a full house, but it's like a sclerosed kidney. And then you have these other patterns like lupus photocytopathy that is usually minimal change variant. And there's FSGS variant, which is very rare. And sometimes you can see vascular lesions with the kidney biopsy, which is thrombotic microangiopathy lupus. And that's, again, very rare as well. But this is very important for the board purposes, as they will ask you questions on what class of lupus it is.
A couple of things that I wanted to add here is when you're making decisions about your patients, it's really important to also look at the activity index and the chronicity index, right? Typically, most nephropathologists will report, hey, this is the amount of activity that's going on, or this is not really that active. Even though it's class 4, it's not really that active. It's a lot more sclerosed. And in those cases, you want to be more careful about the amount of immunosuppression you use. You don't want to bombard somebody with a lot of immunosuppression if they have a lot of chronicity and not as much activity. The other thing that I want to add is whenever you see endocapillary proliferation, right? Think about, you have these glomeruli, which are filters, and you have these capillaries. And if you have endocapillary proliferation, you'll have blockages of the filtering portion, the exact portion where the filtration is going to happen. So you won't have as much filtration happening. That means your GFR is going to go down. So that's the reason why typically endocapillary proliferation is a little bit worse. And when we think about just mesangial, minimal mesangial, it's not really decreasing the GFR as much.
Okay, that clears things up.
What other things do you find that challenge you?
I guess that highlights the importance of biopsying, because if there's different classes and different severities, I'm assuming that affects how we're treating the patients. And that's really the next thing that is pretty challenging to me, is how we approach treatment of different classes.
I feel like this is the area where most fellows struggle because there's so many options that exist out there. Typically, the way I think of treatment is I try to get classes out. So class 6, you don't really want to treat. It's all sclerosis. It's advanced stage sclerotic disease. And then class 1 and 2, typically I would treat more conservatively. If they have a little bit of proteinuria, maybe like a RAS blockade. If somebody's not on hydroxychloroquine, I'd put them on that. But unless they have lots of proteinuria, they often do not get immunosuppression for just class 1 and 2. I will say there's a caveat though. Although for board purposes, you don't really treat class 1 and 2, in clinical setting, you'll often see that these patients will have some extra-renal manifestations, right? So sometimes these class 1 and 2 patients will also end up on immunosuppression, not for class 1 and 2 itself, but because of the extra-renal manifestations.
But you're not prescribing those. That's rheumatology, right?
Great question. Although that is true, we do have a combined clinic, and so we see them together. And then there are patients who are not always able to afford copays and will end up seeing one or the other. So there are some patients who say, hey, I can't get in to see them, or I can just come and see you. I've seen you for a while. And they just continue to follow me along. But that doesn't really apply to all nephrology practice.
But I think what you made is a very good point about class 1 and 2 lupus nephritis. If there's low level of proteinuria, I wouldn't treat. But if they have nephrotic syndrome, then a lot of times they end up having a foot process effacement. So you actually have a minimal change disease on top, or a photocytopathy on top of class 1 or 2. And then low-dose steroids might just all they need, or maybe anti-B cell agents. But that's only if you have superimposed minimal change on top of class 1 and 2. I think the biggest challenge is class 3 and 4.
Class 3 and 4, and I think there's going to be controversy amongst the nephrologists, right?
That's the main movie. So can we go to the trailer before that? I always get worried about the prophylaxis. They're already on immunosuppression. I think it's important for fellows to know that these patients need to be on statins. their high inflamed state. Of course, you need to control their blood pressure with RAS blockade, SGLT2 inhibitors, and there's data now for SGLT2 inhibitors in lupus patients. The one I always, of course, the bone protection, rheumatologists probably are on top of that to make sure they are calcium, vitamin D, and also all that stuff. And we just want to monitor for cancer in terms of prophylaxis because a lot of these are net immunosuppressions. The one that is controversial, and I want to hear your thoughts on this, is PCP prophylaxis or pneumocystis prophylaxis for our lupus nephritis patients. I know in transplant patients, we do put these patients on Bactrim, but do we normally have to put these patients on Bactrim prophylaxis?
So I do. However, only do it if they're on like prednisone, some steroids, 20 and above. So if somebody's on 10 of prednisone, they'll probably come up for prophylaxis at that time. And that's where the controversy arises for us, whether you want to continue it or not. But if they are on higher doses of prednisone, we typically will, especially because they're going to be on long-term prednisone therapy or steroid therapy.
Just for the fellows to know, there is a controversy still about this. It's not written in books. The lupus literature from the rheumatologist side actually shows that actually there's a lot of drug reactions in lupus patients with Bactrim. So 41% actually have a reaction to it. So that's why rheumatologists don't really like giving PCP prophylaxis unless they're on triple immunosuppressive therapy. It's actually by the ACR guidelines, I don't think it's recommended because also Bactrim causes lupus flares. So there is back and forth controversy right now. So you just want to know that because the rheumatologists you work with might have a different way of practicing.
Absolutely. And we oftentimes these patients have a low GFR to begin with. And so we actually end up not using Bactrim for that reason as well, because of the low GFR. So we end up on something like a tovacone. Typically, a lot of these patients might end up on like pentamidine, but then trying to get outpatient in an isolation room, that's a little bit harder. And then a tovacone is something, but patients don't like the taste of it.
So let's go to the movie now. How do you treat class 3 and 4? What is your sort of algorithm or what is the recommended algorithm by the experts?
So let me tell you the recommended algorithm first. One of the things that KDIGO recommends is nowadays triple therapy is a preferred form of treatment, right? So triple therapy means some sort of a steroid glucocorticoid, MMF or cyclophosphamide. And the third agent, if it's MMF, could be a CNI or belimumab. But if it is the second agent was cyclophosphamide, then the third agent can be belimumab. You can do a variety of combinations, but you don't do the combination of cyclophosphamide and CNI at this point, and it's not recommended for induction therapy is what I'm talking about. They also recommend you can do triple therapy, which they prefer, but you could technically do dual therapy with MMF and steroid or steroid and cyclophosphamide and go from there. The cyclophosphamide that more and more people are preferring these days is the Euro-lupus protocol, which is the 500 milligrams every 2 weeks for 6 doses, so 3-month-long protocol. But I do understand that there's some areas where that's not used and NIH protocols are actually being followed, which is the once-a-month cytoxin dosing for 6 months. Intravenous. And then the glucocorticoid regimen nowadays is the reduced dose of glucocorticoids, which is being preferred rather than the higher doses of glucocorticoids.
So reduced dose, you would still give up to 1.5 grams in 3 days of the solimedrol, and then you follow that by 40 milligrams of prednisone down to 2.5 milligrams by week 25. So very similar to the ANCA low-dose protocol, correct?
Correct. I will say that I've now moved more and more towards less amount of solimedrol up front as well.
Mm-hmm.
So I might sometimes do 2 doses or 2 days of solimedrol, so that reduces it, or 250 milligrams for 3 days. So trying to cut it down based on the patient population to also decrease the amount of side effects long term.
Just for the fellows, based on what the experts recommend actually is 2-3 days. But yes, people will have different ways of doing that. And I think what Koyal said is I think it's very important to stress this because this will be the most common type of lupus is 3 and 4 and probably the most asked questions on the boards. So you have to induce them. So we're talking about induction therapy right now with steroids and IV and then followed by oral. That's one. 2, you have to either give them mycophenolate up to 3 grams, but you can actually start off 500 up to go up to 3 grams twice a day, max to 3 grams per day. Or you give them IV cyclophosphamide, which, Koyal recommended. You can actually do combination therapy. If you've given CellCept with steroids or you've given Cytoxan with steroids, can you add a third agent? And the third agent can be either belimumab or Benlysta, which is a BAFF inhibitor, which is a novel drug, and or voclosporin, which is calcineurin inhibitor, or tacrolimus. Most of the US data comes from voclosporin, more of the Asian data comes from tacrolimus. That's usually your induction treatment, which is for at least 6 months, correct?
At least 6 months, unless you're doing Euro-lupus, which is
Yeah.
the 3-month cyclophosphamide. I will say that we made the biggest blunder of not saying this upfront, which is really important, is the anti-malarial agents. That
Yes.
is, hydroxychloroquine has been shown to decrease relapses, not just extrarenally, but also renally. And so it is something that you definitely recommend alongside all of these treatments and is actually safe during pregnancy.
And actually might even prevent lupus flares, right?
Exactly.
So that's usually the induction treatment. What do you do for maintenance for class 3 and 4?
Maintenance therapy oftentimes for me is basically MMF, right?
Yes.
Whatever formulation of MMF. However, there are patients who are not able to tolerate different formulations of MMF and you end up on something like azathioprine. Or somebody is thinking about pregnancy, then you end up on azathioprine. But typically, MMF is the maintenance therapy that I continue and then try to get them off steroids by that time, later on.
Just for the fellows, if you started dual therapy, so steroids and MMF, you continue the MMF up to 3 years. That's the max that people have studied. Some people do 2 years, some 3 years. If you are on Cytoxan, people do switch to MMF for maintenance or azathioprine. What if you were on Benlysta NF or voclosporin NF? Do you continue the dual therapy for 2 to 3 years, or you just take them off the belimumab and voclosporin just to MMF for the remainder of maintenance?
I do continue both the agents. I believe the recommendation is different, 2.5, 3 years for either one, belimumab versus voclosporin.
The other thing just for the fellows to keep in mind is that why are we continuing maintenance therapy was this long? I think studies have shown when you do repeat biopsies or when you try to take them off immunosuppression, the disease does relapse. And even with clinical maintenance, there's actually activity on the renal biopsy even after 1 year. So you want to continue these medications a little bit more longer in terms of maintenance. What about class 5?
Class 5, I think, can be straightforward or not straightforward as much as what you want to think about it. Although MMF is the recommended agent along with glucocorticoids, this is the place where I would prefer a CNI-based regimen over belimumab and or obinutuzumab, which is now the new approved agent.
If you had low levels of proteinuria, you probably just do non-immunosuppressive therapy, right? Although some people will treat for extrarenal manifestations, but just Plaquenil or hydroxychloroquine. If you had nephrotic range proteinuria, then you do this combination therapy similar to what we did in class 3 and 4. Now, Koyal did bring up vitamin R or rituximab-like drug. The rituximab, unfortunately, does not make it to any guidelines in the kidney world for lupus nephritis, although a lot of fellows who are listening to this, they know people have given rituximab. The LUNAR trial was not a positive trial, although people might think it was non-inferior. So people have used rituximab in refractory lupus patients that some of these things fail. And as a result, a new drug, which is vitamin R on steroids called obinutuzumab, it's a humanized monoclonal antibody, showed a really great response in proliferative lupus. They didn't have that many class 5 patients, but we know that from the non-lupus membranous that B-cell therapy really works great with membranous nephropathy. Koyal is postulating from that maybe the best agent down the road to treat class 5 might be obinutuzumab. But right now, you would just treat it like class 3 and 4 if you have nephrotic range proteinuria, right?
And I will also say that a lot of these guidelines came out in 2024, so they didn't really have all the obinutuzumab information when probably they were working on this even a year prior to that.
Just another thing, Mahmoud and fellows, is that we keep talking about voclosporin. Why voclosporin? Because it's the only calcineurin that does not require to check levels. And I think it's very easy to use. Whereas nephrologists, we're pretty used to using tacro and cyclosporin, and it's cheaper. So we do go to tacro a lot when we think of using calcineurins in our patients.
I guess, how do you monitor response to treatment? And is there any role to rebiopsying them, or is there any other clues that can suggest that they're actually responding to treatment?
So we don't do protocolized biopsies, and neither are they currently recommended as a requirement. I would say in terms of monitoring, obviously, it again boils down to the 3 things: the kidney function, the urine protein, and your urine sediment, right?
Yep.
And those 3 things, if they're all improving, think about the partial response, a complete response, which is very similar. There's slight differences between different GNs. Complete response would be something below 300 or 500 milligrams, right, of proteinuria, with the GFR that's maintained within 25%, 20 to 25%. And partial response is non-nephrotic but decreased by half from whatever their proteinuria was, and the GFR is being maintained. So very similar definitions, slight differences between different GNs. Are they getting into partial response? Are they getting into complete response? Are they not responding? How much chronicity did they have? If they did not have a lot of chronicity and they're not going into complete response, then I would wonder, hey, is this partial response? And then I'm just not getting the bang for my buck and I need to either increase immunosuppression or do a repeat biopsy.
Mm-hmm.
Or if I'm thinking, hey, this is actually more chronic, I don't want to increase and add a third agent or a fourth agent on top of this. Should I biopsy them and see, hey, now they just have some secondary FSGS that has settled in and they're going to stay around 1 to 2 gram proteinuria range. So you're trying to figure out how much is active and how much is now just chronic, and you should just not worry as much. Next, what do you have next?
I guess, what are the most common mistakes that you see fellows make when managing lupus nephritis?
I think the most common mistake is probably just not understanding the pathology component. I think there's a lot of confusion, probably class 3, 4, 5, because they're still learning what renal path looks like, and lupus brings in so much pathology variance in terms of which is secondary, primary, and things like that. I think it's probably one. 2 is, when to add a third agent or can just continue 2 agents, when to repeat the biopsy. Probably those are the places where they probably are confused, at least. I think a lot of places, the rheumatologists are running the show and not nephrologists. The fellows also have this assumption of what am I really doing here in the care of this patient. And I think that's one mistake. They give up very early in the care of the patient because they think the rheumatologist will take care of everything.
Can I leave you with a piece of advice? And this is for anybody who's listening to this podcast. It really doesn't matter if you're a fellow or not. I believe that all of us have more to learn and none of us is a true expert, right? We're not the end all be all. And so I genuinely believe that there are complicated cases and you need to talk to each other. There's a lot of cases that I say, you know what, this is really complex. Can we just talk it out? And within our GN team, we will do that. And it's okay to ask for help, right? To me, the patient is primary. And it's not about my ego or somebody else's ego. And you should know it all. It should all be, what can we do?
Very good advice for a fellow who's about to graduate.
Absolutely. And there's still a lot of fellows that I keep in touch with. Like I get texts from them and say, hey, when you have a minute, can you call me? And I call them and then we talk about a patient and come up with some ways to go forward. Because again, in the end, it's all about the patient.
No, I was just basically saying maybe we might have exhausted all the questions Mahmoud wants to ask, but I just wanted to, just because I like TMA, I just wanted to throw in that you can actually have lupus with TMA, and that actually is a whole different mode of treatment. Then you're going into the whole plasma exchange route, make sure you don't have antiphospholipid syndrome, and if you need to give eculizumab or not. So it's very rare. It's probably not something on a board review purposes, but it's like special situations, right? When you have that, or you have a pregnant patient with lupus, what can you use? What are the drugs that are not allowed? The only drugs I know that are allowed are azathioprine, steroids, and calcineurins. But that also only Tacro and cyclosporin, because we have no data on voclosporin and we have no data on rituximab. MMF is dangerous.
Yeah.
See, and we actually have no data on voclosporin with pregnancy and Benlysta either.
And don't forget hydroxychloroquine.
Mahmoud, thank you for joining us for our GN in 10 podcast. I know it's not really 10 minutes, but we really wanted this special for the fellows and hope our listeners learn.
Thank you, everyone, for having me. I really learned a lot, and I was happy to be here and ask all my questions.
Thank you so much for being here. And from all of us at GN10, thank you for joining us and listening to us. Have a great day.
This has been GN in 10 from the International Society of Glomerular Disease. You can listen and subscribe wherever podcasts are found and tweet at us at ISGD Tweets. Thank you for joining us.
BBB, or I don't know what Koyal calls this.
BRB.
BR. What is that? Board review.
Basics.
Oh, God. There you go again. It is board review bonus, by the way.
Oh my goodness. I have never gotten it right in the entire
Well, welcome
history.
to our world. Listeners, this is the problem I deal with.